Welcome to Care Talk, America's home for incisive debate about healthcare business and policy. I'm David Williams, president of Health Business Group.
And I'm John Driscoll, the CEO of CareCentrix. David, is this a college reunion or what? Like, who's our guest today?
It's going to be a little bit of a reunion, John, as our guest is Jordan Rau, and he is senior correspondent for Kaiser Health News, a true blue journalist. And, he does the kind of in-depth reporting that's generally gone the way of the dodo, John, if I may say so.
Come on, just stop. Jordan's done some really good work. Just because you failed to compete with him successfully in college doesn't mean you should sort of undermine his credibility before he even gets a chance to defend himself.
Well, John, I'm sure Jordan is happy to have a fast friend in you. In any case, welcome to the show, Jordan.
Thanks a lot. Glad to be here.
So Jordan, we were kicking it around before we started recording, but tell us a little bit about the state of healthcare journalism, and it feels like Kaiser Health News is a bright light in a fairly dark picture. But is that fair? Tell us a little bit. What's it like?
Don't bias a witness.
In some ways, health journalism is doing really well in that you do have, and I'll back into the negative stuff. You have us. We've been around since 2009, and we have about 40 reporters and lots of editors. So we're sort of the biggest health policy newsroom in the country. And then there are other internet groups like STAT that are devoted to healthcare. But the sort of traditional healthcare coverage has just been hollowed out by what's happened to the news business. And, that's seen most, I think, strongly in, smaller, mid-sized cities where the newspapers that used to have, 1, 2, 3 people who would cover, all of the stuff in terms of healthcare in the community, the local hospitals and whatever story came up. They've all been so hard hit that those positions have disappeared. And so that's really one of the reasons we were created to help fill in on that. And then the other thing is that the internet, before it was the reporters and the editors who sort of decided what was news, and now we don't have quite as much of a vote. And a lot of the stuff that people want to read and that is lucrative and that draws ads is more, consumer-friendly health tidbits, how few numbers of arm reps can I do in order to build my muscle mass before I go back to watching TV. And so there's not as much of a, you need some alternative way to provide more in-depth coverage, which takes a lot of time because, as you guys know, better than I do, the healthcare industry is enormously complicated.
John, was actually going to be John's next question about the arm reps, but I guess
I'm fine. It's you we need to worry about, David.
Yeah.
You need to get it to the gym.
Yeah, you're right. Just after the show, I'll go there. So, Jordan, so say more about Kaiser Health News and what, you mentioned the number of reporters and editors and so on, but how did it come into being, and has it actually been able to fill that void?
Drew Altman, who was the head of the Kaiser Family Foundation, the foundation is it's now a nonprofit charity. It's a nonprofit. It was not affiliated, as we have to say, with every interview that we do related to Kaiser Permanente. And Drew decided he saw the hollowing out that I just spoke about going on in newsrooms around the country. And so he decided to form a news service, originally sort of like an AP type of thing, I think was his thinking of it, that would provide in-depth health policy coverage. And the advantage that we have is that the foundation has a large endowment that funds us. So we don't have to take advertising. We don't have to make subscriptions. We are, so we're in an unusually strong position to do our stories, and we give them away for free to our partner publications. That's been the model. And so we will do stories for, both national places like the New York Times. We do a lot of stuff with NPR, Washington Post. And then we also do stories that go to mid-sized papers and small papers. And then in addition, everyone who wants to pick up the stuff can just pick it up and reprint it for free, as long as they, don't plagiarize it and give us credit. So that's sort of the model. And we started with just 4 reporters, of which I was one. And we've slowly grown. We now have a newsroom in California, about 6 or 7 people, I think, reporters plus editors. We just opened a Southern bureau with someone in South Carolina, and we're going to be expanding there. So, and then we have a large group of people here in Washington, which is where our headquarters are, and we've got people who cover, just sort of all the different sides of the elephant, who specialize in covering the insurance industry and how insurance works, and hospitals and nursing homes, and the Hill, and the politics of healthcare. And we do a lot of stuff on the finances of healthcare, particularly from a consumer perspective. So that's sort of, what we've become. And, we do try and do original reporting that no one else is doing. Because, obviously on certain stories, big stories, there still is a lot of the traditional media covers and, covers well. But we try and fill in and do pieces that no one else is doing, or that no one else, more importantly, has the time to do, and, can spend 3 weeks or 4 weeks or 5 weeks or more digging into.
I think that one of the things that I'm intrigued by at Kaiser Health News as a separate voice is people forget that healthcare is a monster business. It's 20% of the economy. The medical industrial complex is very good in places at promoting its particular reimbursement niche. And one of the interesting things about Kaiser Health is that you're detached from that ad-driven promotional world, and you can report on things like how hospitals that are effectively, in some cases, monopolies raising prices are fulfilling or not their public mission. You go after price gouging that's inconsistent with either the law or any notion of fairness. And I do think that that's a pretty critical investment in something that, regardless of whether you're a for-profit or a non-for-profit, healthcare is part of a public trust. And if you don't have anybody kind of try to pull apart who's winning and who's losing, and whether that public trust serves patients, I think we've lost.
No, I'm back.
Visibility.
Yeah, there was a freeze.
So how do you think about fulfilling that mission, Jordan, of being kind of the productive skeptic of the healthcare industrial complex?
It's an interesting question. Honestly, we do very traditional journalism. Our approach is no different than, when I was at the LA Times or Newsday, in terms of, trying to keep a level of detachment and balance. We're not advocates. And so it really just comes down to, this may sound oversimplified, but just finding good stories that no one else has done, and digging into them. And the good thing about the healthcare industry is you can just sort of pick a topic and there's stuff there. To give you an example, in 2017, 2018, I decided to just go to work on nursing homes because no one had really been writing them. The nursing home industry is sort of a 10 to 20 year cycle of sort of scandal and, investigation and promises for change. And then it just sort of goes back to where it was, and everyone sort of forgets that. And no one had looked into it in a while. And so I just decided to dig into that. And, for me, the finding of the stories is a combination of sort of shoe level reporting of the type that we always do traditionally, of talking to people who are experts, but also more recently, it's been a lot more of data-driven reporting, because there's such a larger wealth of mass data sources that are public, that are available, that we can mine for stories that didn't exist 5 years, 10 years, 20 years ago. So we use a lot of those to find and to document good stories.
I think it was back 5 years ago or so, you were working on the nursing home stories, and I saw an article, I think, about lack of proper infection control at nursing homes, which certainly became, maybe it was a niche story at the time, but became front page, news, and dominated the national conversation a couple of years ago. Did your reporting have an impact at the time, or was it just something people kind of looked up later and said, oh yeah, somebody actually mentioned this 3 or 4 years ago, we should have looked at it?
Yeah, it had no impact at the time that I can think of. It's been the approach that we took has been some government reports have sort of mimicked it since, but but at the time it was just sort of like, yeah, whatever. And it turned out generally my stories aren't very prescient, but that one ended up being, and that one was it was one of those stories that's like lying in plain sight if you look for it, and that's because if you look at so nursing home deficiency records are public, and basically, the inspectors come in and they'll ding a nursing home if they're failing for this or that, and everything's got a code called a tag, and it's not too hard to untangle once you sort of get through it. And that story was just like looking at that data and asking a very basic question, which was, what's the most common problem in nursing homes? And infection control popped up. And for the most part, it wasn't, each individual one isn't sexy, because like you'll have these inspectors come in and like, oh, you didn't wash your hands, or this person got an infection because you weren't turning them into bed every 2 hours, so they got a bed sore. But so that's where that story came from. So it was sitting there, but no one was paying attention until COVID hit, and now, of course, everyone's all over it. And we actually did right at the start of COVID. I was like, not only should we repost that story, let's just rerun the story with the more up-to-date numbers. So we were able to turn that around pretty quickly. But that, like I said, for the most part, I find like sort of the more comprehensive an analysis you do of the problems in the healthcare system, the less likely they are to lead to a change or to results. Like, it's sort of, you can find a rotten apple in the barrel, and then the apple gets in trouble. But it's a lot harder when you're like, this entire barrel, the way that it's constructed is really messed up and it's all jerry-rigged. And then they're like, well, I know, but we need the apples. So that's the backstory of that one. And, I wouldn't say that, and I certainly didn't predict that, something like this was going to happen with COVID. But, at the time, there were a lot of other infectious diseases that were just running, through nursing homes very quickly.
So if you think about the President Biden is now coming out and demanding better performance and more transparency and higher fines for a nursing home industry that, I don't know, but is it fair to say that about half of them have had some problem with regulators over time? I mean, this is not a high performing part of the most expensive healthcare system in the world. How is the nursing home industry going to be able to cope with higher fines, more transparency, and more demands for staffing, because staffing drives a lot of this, when it's kind of a failing industry to start with?
Yeah, well, I mean, I guess so. The Biden proposal was put out, and I don't want to call myself cynical or skeptical, but it's a long way from issuing a proposal and seeing it in the world. Like, so I'm, I don't know which pieces, if any, will come to actually be implemented. I mean, are they going to mandate, high levels of certified nursing assistants, licensed nurses, and registered nurses in nursing homes? That's got to go through a rulemaking process, and there'll be strong industry opposition to it. Are they going to increase the maximum fine from $21,000 to $1 million? That needs congressional approval, and I'll just leave that there, and you guys can assign the odds to that one. So, I would say, I think that what they've asked to do in terms of staffing and performance, it's very significant. It's together, it's the biggest change since the congressional omnibus bill in 1987. But the industry is very influential, and it also has some strong arguments, which is that a lot of these changes are going to be major costs, and no one really understands, how profitable, unprofitable each nursing home is, because the finances are so opaque.
Well, nursing homes sound like a lost cause, but thankfully we still have hospitals. And you've done some reporting over there as well. And I found it interesting, clearly with the arrival of the pandemic, there's a lot of money funneled to hospitals. And you did some interesting reporting about how that has gone, especially for some of the hospitals that were already in a strong position. But what have you found there in terms of the hospital performance during COVID?
Yeah. So hospitals like nursing homes, it's always a danger to generalize because they're so different in terms of, their situation. So, hospitals run from, very big money making medical institutions that have, a majority of influence in negotiating with insurers to these little tiny community hospitals that have mostly poor patients and they're in really bad shape. So, one of the things that we looked at was the giving out of provider relief funds from Congress, which was one of the ways to help keep hospitals afloat at the beginning of the pandemic, particularly when their big source of income, elective surgeries, was shut down. And, and we both, pointed out that this money was going not just to hospitals that indisputably needed it, but also hospitals that were just awash in cash. We're sitting on, half a year in cash, and just laid that out. And then we came back to it sort of at the tail end to take a look at how hospitals did. And again, it was what you would expect, in that some hospitals ended up getting more federal funds and provider relief funds than they actually needed. And the way that the money was rushed out, they kept it. And, so that's sort of, I would say that, the federal funds and funding of hospitals, and just in general, how hospitals are paid is one of the more important things that we try and cover, because so much of the cost of your health insurance is related to that and driven by that.
I don't think you should give up on nursing homes, David. You're getting kind of up there. I mean, you
Thanks,
can end
John.
up in a nursing home.
Yeah, appreciate it.
I don't think that's a legitimate thing to give up on. It still is a big piece of the whole healthcare system, and it's I run a company that tries to create more healthy days at home, and we're competing with nursing homes because I don't think certainly my 87-year-old mom that really wants to spend any more days in or near a hospital, a doctor's office, or a nursing home than she has to. But there are people who have to be in nursing homes, and I think it's a failed reform, Jordan. If let's say all those things go through, you up the fines, you create transparency around the hodgepodge ways that people finance and own nursing homes, really for the real estate and the fees versus the patient care. And you don't fix the reimbursement to the nursing homes, because fundamentally a lot of those days in nursing homes are paid by state Medicaid budgets or commercial insurers that aren't really funding at a level where you could support the staffing that people need to get the care of some of our most vulnerable patients. There's certainly a bunch of people you could care for at home, but we're still going to need nursing homes. And I've been really intrigued by your reporting, but I guess my question is, do you think you could actually push through the reforms without substantially increasing the reimbursement? What the cost per day that patients charge to either the state Medicaid budgets or to insurers?
Well, I would say, we look at some of the states that have done it, like California passed a minimum staffing, several other states have passed it. And, and the problem, there's two elements. One, you've got to be able to figure out what a facility's real cost is, right? What they're actually running on. And that's difficult. But part of the Biden reform aims to do that. It aims to take a better look at how the actual, how money is spent, what profits are, where they go, and to sort of catch some of the ways that some of the less scrupulous owners siphon them out. But then you've also got to have something for the nursing homes that are truly in trouble. Like California has you can get excused from it. But as you say, that doesn't solve the problem for the patients, right? I mean, you can't have bad nursing homes, and the Medicaid funding is a significant problem, for all nursing homes, and that's something that, I mean, I'm not a reform person. I don't know how you get that, but states are getting that increased is a tough one. So you have to do that both on a federal and state level, but that's not really my thing. But again, how much, what is the right amount? And one of the amazing things about a nursing home is I don't think that you can find anyone that says, if nursing homes got, X amount of Medicaid payment, they would be able to do all these things. I mean, no one really understands what they are. And so for this incredibly expensive industry, and this is true of all of them, you don't have the type of internal analysis. And that's why there's just money awash everywhere, because some places, and this gets back to the hospitals, some places are just rolling in it and other places need dramatic help.
So, John, I know you want to stay in the nursing home, but I want to go back to the hospital, among two great choices. One of the things the Affordable Care Act was supposed to do was to reduce or eliminate medical bankruptcies. And I think it's had some good impact there. But you've also looked into this issue about charity care that's provided by hospitals. And there's a lot of tax-exempt hospitals that are supposed to provide charity care, but it's not automatic. And I understand that, partly from your reporting, that a lot of people that should be offered charity care instead of being sent to the debt collector. What's the latest state of that?
So most hospitals, almost all of them, have some sort of charity care policy, which says, if you make less than 200 or 300% of the federal poverty level, we'll lower your bill. And the number of people that are getting totally bankrupted has definitely gone down since the passage of the Affordable Care Act, just because you have more people insured. And also because the act got rid of some of the less comprehensive insurance plans that, would cap out at a certain amount and leave people on the hook. But there's still a lot of people that, because they have high deductible plans, still are walloped by a hospital bill. And, if you make, what's the median, family income in the country? It's $50,000. And, some people have insurance policies with a $6,000 or $10,000 out of pocket maximum. I mean, that can just destroy you. So in theory, the hospitals should be cutting those bills for those people. What our investigation had in 2019 was we looked at how often they didn't actually help the people get through those, the process of applying, or didn't tell them about it, or whatever, and that people ended up getting these large bills for care that they should have gotten excused for. And that, again, sort of goes back to the consumer unfriendliness of the industry, of hospitals, of nursing homes. I mean, none of these places are organized in the same way that, your grocery store is. It's really hard to find what you want on the shelf. And so, I think that continues to be a problem, and people continue to have, really big bills. And we actually run a monthly feature with NPR called Bill of the Month, and people can submit,
we love that one.
Yeah. It's really been really amazing, and I've been really amazed at the different stories that we get. And so people will just write in and they're like, here's my bill, and I went to this hospital, and they charged me $1,000 facility fee because I went into the ER, but it turned out that I only saw a nurse practitioner, and they billed me and my insurance for the highest level, the level 5 reimbursement. So now I'm on the hook for this or that, and it's become, unfortunately, a very successful billing sort of fixing plan, because so many of the stories that we do, we'll be reporting it out. We have the bill, you call the hospital, and then the hospital is like, oh, and then they freak out, and the public relations people get involved, and then they, cut a deal for.
You say that, Jordan, but I was listening to that terrible story of a couple that was, it's a Kaiser Health story, that had a baby that was premature, with a surrogate, and Cigna was sort of denying the emergency surgery for the birth of a premature baby. It was insane. Yeah. And the family had spent thousands of dollars trying to resolve it. It's still pretty outrageous that what insurance companies and hospitals get away with at the margin. And I'm still kind of stupefied that folks would sort of stand on ceremony and not realize this is a service industry, that the reason why we give it a lot of extra cash and capital and room is because it's supposed to be patient friendly. And I still think that that is an incredible public service for anybody out there who's got an outrageous bill that doesn't make any sense. You should submit it to the Kaiser Health News and see whether you can win the lottery and have someone try to fix it. Because look, all healthcare bills are complicated. David and I are both in the healthcare business, but the moral responsibility of the companies is to try to figure out how to help the patients, not to stick them in the middle. And it feels like that's kind of the whack-a-mole problem that the regulations haven't solved for.
Well, why don't you? I mean, you guys, in some ways know a lot more about this than I do. I mean, why do you think that the, hospitals and insurers and all these places are the way that they are?
David, you can take a shot at it. I've got lots of opinions.
Yeah, that's a tough one. I think partly what happens is when you sort of shine the light of day on something that's normally in the dark, you see a lot of ugly rats and stuff running around that you weren't expecting. Partly is that if you have a regular business like a grocery store, which you were describing before, you come in, the price is what price, it's on the shelf, you see what it is, you pay it, and the grocery store knows how much they're charging, and the customer knows how much they're paying. A hospital sees somebody come in, and this person may be paying zero, or they may be paying $1 million, and it's very arbitrary. And so I think it's just sort of within that context that they're working individual patient by individual patient, and they play by the rules such as they are, and you get to these weird results. So that's my 45-second answer.
I think it's a little simpler. I think we've tasked the health insurance industry to bring costs down. So part of that is shifting responsibility. And we aren't always clear about, from a regulatory standpoint, what those lines are. But that's the job of the health insurance company. And they disappoint me on a pretty regular basis. They're my partners in a lot of parts of the business, but they are kind of doing a job. And I think the lines aren't always clear. And you really have to rely on the moral character and the values of those organizations to navigate around the complexity to get to the right result, to keep the patients in the middle. For hospitals, for the life of me, I can't figure out why hospitals in many parts of the country are the most reliable people, shifting people to the debt collectors and bankruptcy. I mean, there was an outrageous story about Yale New Haven Hospital in the Wall Street Journal years ago. That was one of the most common sources of bankruptcy in New Haven County was hospital bills, and I can't fathom why hospitals would stick tax-free institutions with massive public subsidies would stick poor working class people or people who are broke with bills they can't pay. I can't. That's something that it seems counter to the entire mission of hospitals and doctors, and I can't fathom that. And I think we're going to have to. What we don't see in the market in terms of moral fiber, we're going to have to solve with regulatory requirements, because I think it's gotten better, David, but I still think it's a real problem. And I think that the way you're describing it gives too many excuses to the people in responsibility who are well paid to make sure that poor people and people in need get taken care of.
Well, John, that's one of the
regulatory solution.
John, that's one of the nicer things you've said to me today. So I think given that, I sense a turning point also where we go from asking the questions to have a professional question asker start asking us questions. And I think that's a pretty good place to end it, John, before we get ourselves in any more trouble. That's it for this edition of Care Talk. I'm David Williams, president of Health Business Group. We've been joined today by Jordan Rau. He is senior correspondent for Kaiser Health News. And I want to thank you for joining.
Thanks a lot. And see you at, our 80th reunion next time.
And I'm John Driscoll, the CEO of CareCentrix. Thanks for joining today. And if you like what you heard or didn't, please subscribe on your favorite service.